Welcome to the NEI podcast. On this show, psychiatrist, psychopharmacologist, and mental health advocate, Dr. Andrew Cutler sits with renowned mental health experts from a range of backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions.
Hello and welcome to another NEI podcast. With me today is a very good friend who's done some very important work in the field of stigma and mental illness. And so no one better than my friend Dawn Velligan to join us today. How are you, Dawn?
I'm good. How are you doing?
Doing great. Well, we're going to be talking about various aspects of stigma in the mental health world and how that impacts what we all do every day. Let's get started and just kind of help the audience understand, what are we talking about when we talk about stigma exactly?
So I think there's different types of stigma. Stigma is the sort of bad label or, shameful label that people have associated with having a mental illness or dealing with people with mental illness. And so, the person themselves can have self-stigma where they have an internalized sense of stigma where, because I have an illness, right? There's things that I'm not going to be able to do. I'm not going to try as hard, or I'm not going to expect things of myself because I have this illness. I may never get this or that other people in life have. And then there's stigma that's put on to us from society, really, from the people that are around us. So with respect to them, it's more like, that person has mental illness. We need to stay away from them, or we have to watch what we say, or we can't expect certain things from them because they're sick. And so society has a stigma toward people with mental illness as well.
To what degree does media contribute to this societal stigma, do you think?
I think that media certainly does contribute. I think many of the portrayals of people with mental illness are, that they're dangerous, or that they're somehow, serial killers. And I think that the media portrays people with mental illness typically in a very bad light. And a lot of the myths are sort of perpetuated by the storylines that they put out there for mental illness. Yeah.
But also in entertainment, in movies, TV shows, things like that, very often. Sometimes, lately, I guess we've seen some positive representations, but you're right. It's either they're to be afraid of, they're dangerous, or they're incompetent somehow, or unpredictable, unreliable, those kind of things.
There's a few good movies that portray sort of the sense that someone who has a serious mental health challenge faces, right? So there's some good movies out there that show things in a light that helps us understand what people are really going through. So, many people saw A Beautiful Mind, and they could see what it was like to have a serious mental illness and to believe things that other people didn't understand, and how that person was treated.
Yeah, one of the greatest representations in film of psychosis. I don't know if you ever saw the movie The Fisher King with Robin Williams.
Oh, yes.
Tremendous scene there where, the representation. So there are, and of course, some famous people with mental illnesses coming out and talking about their experiences, I think has helped. And even COVID has kind of brought this, I think, to light in a somewhat positive way. Would you agree?
I think so. I think because of COVID, many people, were stuck at home with their own thoughts. And our own thoughts are kind of our worst enemy. And so many people started experiencing anxiety and depression for the first time in their lives. And I think that makes people have more empathy. I think that makes people understand the struggles better of people who have serious behavioral health challenges.
Boy, that's such an important word, Dawn, you just used, empathy. I think that we need more of that in society, don't we? That would really help. It's not hard to empathize with somebody who has cancer. It's not hard to empathize with somebody who's had some kind of terrible accident or disease. Why is it that we treat mental illness, brain disorders differently?
I think people are afraid. They don't really see brain disorders as a disorder. I think many people see them as weak character or a character flaw. And that's not at all what it is. But I think that that might account for some of it. In our language that we use when we're dealing with mental illness, is also contributory. I mean, we used to call people schizophrenic or manic, instead of a person with schizophrenia or a person with mania. And so they became the label. And so a lot of even professionals had stigma in the way that they talked about mental illness and in the way that they treated people.
Right. So rather than seeing them as a person or an individual, it was just sort of one category. I think you're right. One of the things I was thinking about as you started off earlier talking about stigma for the patient is how they can confuse the illness for themselves and personalize it and think that I'm not worthy or I'm not capable. All of these things instead of, well, I have this condition that I'm dealing with, just like somebody with insulin or, with diabetes or heart disease. You don't see them as not being able to function and overcome that.
Well, there are functional limitations with any kind of physical illness. When people are going through chemotherapy, a lot of times they have trouble going to work and they can't be as dependable as they'd like to be because they're sick. And we don't give that same kind of leeway to people with mental illness. When we joke about maybe taking a mental health day, right, at work, but we don't think anything of people taking off because they're trying to deal with a chronic illness or their diabetes is poorly managed or whatever. But we don't really have a way for people with behavioral health challenges to say, wait a minute, I just need some time to pull it together.
Yeah, and the fact that we don't give them space to recover and say that they can recover, that there are periods when they're not incompetent or unable to function, just like with other illnesses, I guess. I'm curious about what some of the misconceptions or biases are that even healthcare professionals may hold and how we can maybe address these.
I'll always be this way. I'll never get better. I think that both the person with the illness and the person treating the illness, often have those biases, right? And so it starts to become part of people's personality. Well, I just have depression, so I can't do this or I'm not going to enjoy that. And they don't see things as changing as much as the world changes and that they're sort of stuck. And professionals sort of feel stuck as well, that, I've tried this and I've tried that and nothing I do is helping, and it can get very frustrating for them as well. So it's this idea that nothing's going to get better. And I think that hopelessness kind of perpetuates itself.
Boy, that is so well said, because we all know how challenging it can be to work with people with especially serious mental illnesses, more SMI. And we've kind of been told, here's the next breakthrough, here's the next great medication and treatment. And, the fact is our progress has been incremental rather than really the kind of thing we'd like. So I think you're right. There's a lot of either nihilism or frustration. People get kind of tired. And I think that people start to lower their expectations. Well, this is as good as it can be, that kind of thing.
Yeah. And I think that's a big issue, is that we don't expect any more of our medicines or we don't expect any more of our treatments. And, I have people that are on the best of medicines and they continue to hear voices every day.
Sure.
And they continue to have to do everything I do, go to the grocery, go to work, maybe take care of children or whatever, when they're hearing voices every single day. And I have a tremendous amount of respect for the individuals that have these illnesses and how well, in fact, that many of them cope.
Yeah, that's well said. I think you're 100% right. I always say, why is it that we don't expect the same things for our patients that we would for anyone else? Why is it? Maybe these people won't achieve the same level of function, but why can't they have something meaningful in their life, something to do, something to look forward to? Why can't they have relationships?
I think they can. I just think that, first of all, our medicines don't treat that, right? So when people go to a psychiatrist, it isn't to get friends. It's to get their symptoms under control. So there have to be many other psychosocial treatments available. And my personal bias after dealing in this field for more than 3 decades is that we know how to help people with serious behavioral health challenges. The issue is it going to be available to them?
Right.
Is it going to be paid for? And I think that we know many ways how to help. Medicine just sort of forms the foundation, and hopefully we'll be getting better medicines that actually treat people, to a state of being more well. But then there are all the residual things, you've been ill for years and you haven't developed the friendships you want, or you haven't gotten the job history that you need. And so it's starting to help people develop that so that their lives can be as rich and meaningful as everyone else's.
Boy, that is so well said. I sometimes use the analogy of diabetes again. You don't just throw insulin at people and let them eat all the chocolate cake they want. You have to use the insulin to control the glucose. And then, of course, it's, learning things, it's diet and all these kind of things, lifestyle. I'm curious too, how does stigma affect the accuracy of diagnosis and treatments for people with mental illness?
Well, if I'm ashamed of some of the symptoms that I'm having, I'm embarrassed that maybe I hear voices, or that I'm so depressed that I can't get out of bed and take a shower. I haven't showered in a week. If I'm embarrassed about those symptoms, I may be reluctant to talk about them with a treating professional. I may sort of minimize them so that professional doesn't know how bad things are. I don't really want to get a diagnosis because, some people see a diagnosis as the kiss of death, right? Sure. And so there's a lot more, you're a lot less embarrassed about physical pain for some reason than psychic pain. And, you don't want people to see you as weak or like you can't handle things. And so we're maybe not as honest about our emotional symptoms as we are about our physical pain. And that kind of can cause trouble in terms of the diagnosis. Yeah. I think also we may expect too much from our medications if we're not prepared. We might think, oh, well, medications are supposed to take this disease away, right? They're supposed to cure it. And when that doesn't happen, we might just throw them in the bin, because it wasn't working. And so I think we have to set the expectations for people that come into treatment about what our medicines can and can't do, and what other kinds of things we need to do to help them to build that meaning in their life.
Yeah. Again, very well said. I think moderating expectations is so important, both short-term and longer-term. I really think, again, sometimes our goals and our expectations sort of adjust to the level of what historically what our medicines have done. And then I think people tend to narrow their lives down and lower their goals and expectations because, I have this terrible diagnosis, if you will. The other thing that we have to be honest about is the very real issue around job, insurance, things like that. They do treat a mental diagnosis differently from a physical diagnosis.
They do, and I think it's really scary. I have a young person now who has a serious mental health challenge, and he's had about 5 jobs in the last 3 months, and he wants to work full time, but he's afraid of losing his benefits. And it's not just the monthly income, because I believe that, and he believes that he could get the monthly income for working, but he can't afford his medication, and so if he loses the ability to pay for his medication and his new job doesn't have any insurance, then he's not going to be able to maintain and keep going. And there's so many disincentives for people to work with this disorder. Yes. And there's an occasional program here or there that, we'll get you back to work and you'll have 3 years to keep your benefits and see if it works out. But they're rare. They're hard to get into. Nobody knows about them. And so we just perpetuate this long-term disability, and it doesn't have to be like that.
Boy, Dawn, you just made me remember a young man I had in a long-term LAI study, an atypical LAI, and he just did so well that he was able to get out and work, and he ran into that problem. He started working more and more, and he temporarily lost his benefits, and we had to work to restore them, and he had to pull back on his hours, and it just was a really funny, perverse disincentive.
It's a huge disincentive, and it's something that could be fixed. I mean, if you were able to work and keep your benefits, you could contribute to the tax base. You could have a meaningful life. You could have a job just like everybody else. And because of the way it's structured, they can't do that. And that's just not very fair.
Well, that's something I hadn't considered, Dawn. We're talking here about systemic stigma almost, aren't we?
Yeah. Yeah, because I mean, I think level. we have these sick pools for people who get, cancer or long-term illness, and we donate to that. And we have accommodated physically ill people and how we can do that in the workplace. But we have not done the same thing for people with mental health challenges.
Well, for our audience listening, Dawn, what role can we as healthcare providers play in addressing and combating this stigma? Maybe even within our practice and our patients, but even in the wider community.
I think there's a number of things. I often, refer students and other people to mental health first aid and mental health awareness courses so that people can understand what it's like to have these illnesses. I want them to see them from the perspective of people who have the illness. And I think that's one way. I think we can also educate. We can provide education to families, because families have a horrible job dealing with stigma. They're so afraid that people are going to shun them because they have a relative with mental illness. Oh, nobody will want to come over, or we're too embarrassed to have people over. And so their lives shrink as well in terms of who they have access to. So really helping families to understand that this is a biological illness and that there's nothing to be ashamed of, and that they don't have to take on this idea that, oh, we can't have friends over, we can't go out and leave this person alone. So there's a lot of work with families that's really important. And I mean, I think we should start educating in schools. I know my son went to a school for individuals with different kinds of special needs, and he had many people in his class who would hear voices, and he just thought it was something normal, right? And he didn't come away with stigma for mental illness that many of us get when we're segregated from people who have those kinds of problems.
That is another excellent point, Dawn. We do segregate people, it seems like, with mental illnesses. And so for the wider society, the wider community, I don't think that they always have a lot of personal exposure to this. I mean, yes, these are common illnesses and many families deal with them. But in the wider community, and what I always find is that's the best way to combat is to meet individuals rather than to, stereotype a group of people.
Well, and it's funny because I help to run some of the homes for people with serious mental illness where they can have supervised medicine and they can, go out and work or do whatever they do during the day. And nobody wants it in their neighborhood. We get calls from the police all the time because people are trying to push them out of the neighborhood. And that's another sense of stigma, like it's not going to be safe.
Yes.
And that's just not true.
Well, we certainly know, mental health professionals, we know that actually people with serious mental illnesses are more likely to be victims of violence than perpetrators. Now, we do know, however, that when people with psychotic disorders are not adequately treated, yes, there is the potential for violence. But in the situation you're describing, those are people who are stable and getting medication. So, this is a real issue.
Yeah.
And we've all, of course, we're very sensitive to the mass shootings that are going on. And unfortunately, some of these shooters, perpetrators have had untreated or inadequately treated mental illness. And that furthers a stereotype.
Yeah, that complicates things a lot. But again, it's because they've fallen through the cracks in terms of having appropriate treatment for their illness. Yes. And, you know, I often tell people it's important not to wait. You know, it takes a long time sometimes to convince someone that, you know, something's going on with their child. And they don't want to admit that there's something wrong. It's scary to admit that there's something wrong. They explain away behaviors that are really hard to explain away sometimes. They have high levels of tolerance for things that, you know, should be obviously, oh, this is a problem. But it's scary too, navigating the mental health system. Who do you call? I'm in the field and sometimes I can't get treatment for people that I know. And so they don't even know who to call or where to go. Right. And there's a lot of places that, you know, maybe aren't that good. And so it's really finding a good fit with a treatment team that, you know, you can work with.
Yeah, we just went out to dinner literally last night with a good friend in the neighborhood, and she was confiding to me about her daughter's crippling anxiety, and she told me that she went to get help, and when she told me the medication this provider chose, I was very surprised. It was not the right choice, to put it mildly. But you know, Dawn, when you talk about early intervention, this is also very important, and I know you've been thinking a lot about this. We are learning that these illnesses can be progressive and damaging to the brain if not treated. And so I like to say sometimes literally time is brain. And we know that the best outcomes are when somebody is treated early and effectively. So you're right, that stigma even affects that. And I think for a lot of families that I've worked with, there's an overwhelming sense of guilt that you don't see with other illnesses. You don't see families beating themselves up if a young person in their family has diabetes or cancer, for instance, some kind of genetic disorder. But yet they do. They feel like, I remember a mom vividly who was just beating herself up because she had drunk some alcohol during her pregnancy and thought that caused it, or something like that, bad parenting or something like that.
Yeah, I mean, I think parents in general do feel guilty. Like, what did I do to cause this? And it's tormenting them. And I think that many parents then overcompensate by doing everything for the person with the illness.
Oh, I see.
Which kind of prevents them then from learning their own. I mean, we'll go to people's homes and we help them to try to develop more independence. And sometimes, you know, the moms hold on to those jobs like laundry. I have to do this for him because he suffers with this illness and I suffer with him. And so we have to get them to maybe let go of one thing at a time so that we can get the person to be more independent and be able to live their own life. There's a lot of ideas that, oh, well, these people, you know, need a guardian and they can't live their own life and they can't make their own decisions. And all of that's not true for the vast majority of people.
Yeah, there's that stigma again, isn't it? You know, the stigma that this person can't do even simple tasks for themselves or can't be independent. There's a lot to address here for sure.
Well, that's why treatment has gone so person-centered, right? It's what does the person want to work on? What is the person's goals? And you know, whatever it is that they want to work on, we can make approximations to that until they are able to reach their goals.
Yeah, that's the concept too. It brings in the concept of shared decision-making. People are able to make decisions about their treatment, about their goals, about what kinds of interventions they can work with and which ones they'd rather not. Our friend Les Citrome, I think, calls these values and preferences, which is an interesting way of talking about it, and goals. So for healthcare providers, I think you've given us some things to think about. First of all, we do need to examine our language a little bit. As you mentioned, the idea of that patient is a schizophrenic rather than a person with schizophrenia. I think we have to evaluate our expectations. We have to evaluate our ways of interacting with our patients or clients and families. You've made a really good point about that. The other piece we haven't talked about, Dawn, is cultural factors and cultural issues. This is clearly something we all know about. Different cultures approach mental illness differently. How do we recommend that people think about that?
I think it's kind of difficult. I have lots of patients who've gone through exorcism, for example. based on their family's religious preferences. And
sure.
It was a very frightening thing for them that added to their sense of trauma, their sense of isolation in some cases. In other cases, those kinds of rituals help the person.
Right.
And so it's really being able to work within someone's cultural system to understand it and to take what's good and helpful and use that in the treatment and to work around some of the things that are less helpful so that you can help that person to be as independent as possible. I mean, some of the family therapy we used to do, look directly at your father and tell him how you feel. That's not going to fly in some cultures. It's just not. So the therapy has to be adapted to fit in with certain cultural norms that are accepted.
Yeah, that's really well said. I mean, certainly when I think of certain minority communities, I know mental illness is treated differently. For instance, in the Hispanic culture, I know where you practice, Dawn, you have a very large Hispanic population in Texas. Certainly in the Asian community, I remember giving a series of talks in Southeast Asia a few years ago, and there were lectures. We had lectures on how people in the Asian culture, people in the East, present differently with depression and how they talk about symptoms and depression versus people in the West. Certainly the African American community has different ways as well. The concept of self-reliance versus family and community is different in different cultures, for instance. So
it absolutely
I think it
is.
Yeah.
And you have to learn to work. You have to learn to work within these different cultures and to adapt the treatment so that they fit. So you would never want to take away all of the mom's jobs because that's her role. Her role is to be the mom to this person and to take care of their various things because they're ill. You don't ever want to take away her role. You just want to help her to shift some of that role so that she can support that person becoming a little bit more independent. Because the big issue with families is they're not going to always be there. And, if there's too much reliance on a very small family system, then things can be much harder for the person later in their life.
Yeah, so you're setting them up to fail, if you will, instead of setting them up for success, I guess. So I guess it does come down to independence, as much independence as is practical for that particular person. So maybe even thinking about how to assess that. What is this person capable of? What are their capabilities?
Well, and I think with respect to that, a lot of professionals underestimate what people can do.
There you go.
And I think because of stigma, our expectations, that person probably isn't going to be able to do this. And I have been humbled many a time by
Just gonna say, me too.
People. I had this one man who'd been mostly in the hospital for the past 17 years, and he came out due to a special program in Texas and, very delusional, very ill, having a lot of voices all the time, and he was able to work,
wow.
Probably 30 hours a week for an extended period of time, even though he'd been institutionalized all that time. And I think, we don't realize what people are capable of, and we have to not limit what we think people can do. And now with the peer movement, there's a lot of peers helping one another. So we have a clubhouse in Texas that has a lot of peer counseling and peer support, and they run the whole thing, and they do an excellent, excellent job.
Boy, I absolutely agree. That's been my experience in Florida too. The clubhouse model and peer counseling in general. For all of us, we all, I think, do better when we realize we're not alone and there are others who've been through it and can hold up for you maybe a different way of thinking about what you are capable of. And
peer counseling has been used for years and years in terms of addiction, in terms of the addiction model.
That's right.
But someone somewhere just figured, oh, well, these people have mental illness. They can't possibly help one another. And that was a big mistake. And I think the peer movement has really taken off in the last decade. And they can help one another understand how to navigate the system, how to choose among a variety of treatments, etc.
Yes. Yeah, exactly.
That's
really well said. Yeah.
The media and some of the stigma coming from there, I just thought of this, especially like about ECT. ECT is one of those treatments that works really well for depression and sometimes for psychosis. I mean, just amazing, amazing result. But because of the way it's portrayed in the media, people are afraid of it. People think, oh, you must be really, really sick if you have to have ECT. And so they don't get needed treatment because of the stigma that's been associated with that treatment specifically. Or because of a drug is called a certain kind of drug, they don't want to take that drug. It might be an antipsychotic or this or that, not realizing that our medicines work in a variety of different illnesses, right?
Yeah.
There's a lot of stigma that's attached to the treatments themselves.
That's well said. We hadn't talked about that, certainly. That's a common problem. If I prescribe, and many clinicians listening to us will probably relate, when you prescribe an atypical antipsychotic, let's say for a mood disorder, we get pushback. Someone looks it up or they talk to the pharmacist and they see, oh my God, what are you? I'm not crazy. I don't have schizophrenia. I'm not psychotic. So you're right. We have to do a lot of educating around that prophylactically about how these medicines work. And then I think you're also right. With many other illnesses, there are very aggressive forms of treatment. I mean, chemotherapy is an incredibly aggressive form of treatment, but it's not as stigmatized as something like ECT, which you're right, has a very high success rate, actually.
It does. And so many people won't even consider it because of what they've seen. And they're so afraid of it.
I agree. I think people are afraid, like you said, of the diagnosis. And I try to help healthcare providers say, look, this is an important day to make the right diagnosis because at least then people know what they're dealing with. And now you can have realistic expectations and a realistic treatment plan here instead of denial or going along and setting people up for failure. So there's a fear within us. I've had many clinicians say to me, well, I don't want to make that diagnosis. I don't want to get them mad at me, if you will, or it's a death sentence, as you said earlier.
Yeah. So we're very reluctant to tell someone you have, say, schizophrenia or your relative has schizophrenia because of the way we look at it, because of the way they look at it. That, it means, this prognosis or that. So I do a lot of normalization with families and with people who have serious behavioral health challenges about, look at all the famous people that have this and look at how far they've gone. Look at, everybody has the ability to misinterpret a situation. Everybody has that. These are human traits, right? They're not just things that you have that no one else has. And I think that can go a long way in terms of treating an individual and their family, that there's nothing you can't do just because you have this diagnosis. It's like, even if you have cancer, there's nothing you can't do just because you have cancer,
That's really well said. I sometimes think, Dawn, the brain is so complicated that I'm almost amazed when it does work properly or when there aren't glitches. And the fact is that I had a professor who used to say, if you stress anyone enough, they will become psychotic. I mean, we can all be overwhelmed and we can all suffer with temporary, if you will, emotional and mental situations.
Maybe it's just me, but I don't know anyone who's normal.
Yeah, I don't know what normal is. But I do know, one of the reasons I went into this field is I just found the brain so fascinating, complicated, and interesting. And just like the people with these illnesses all present differently, there's always a personal or individual touch. We know about hallucinations, but it's interesting that people have very personal hallucinations with personal significance to them, all hallucinations aren't the same. Same with delusions,
That's absolutely
So
true. It has to do with a person's personality and their worldview, from before they even got psychotic. We all have our own way of looking at the world and our own way of looking at things.
Sure.
Yeah.
No, our family we're brought up in, our culture, our history, what we're exposed to, whether it's literature or whatever, media, as we said, all these things play into it.
Well, and I think social media is kind of a double-edged sword with respect to stigma, because I think that, there's a lot of portrayals you can look anywhere. Oh, I have bipolar disorder, or I have treatment-resistant depression, or I have this or that. And people talking about their experience. And I think that's very valuable. But then you have all the trolls that are attacking those same people and attacking people who show vulnerability. And I think it was Simone Biles didn't compete, and one of the tennis players didn't compete because the stress got too high, and they said that's it, and they did the right thing for themselves,
of course,
right?
Of course.
But all this outside pressure, oh, what a wimp, and they get called names, and they get a lot of pressure.
What if they had a strained ligament and they decided to take a couple of days off to recover? Hello, you would never stigmatize them for that.
Never. And so the treatment of these athletes who say, they're stressed and they need a break is so different from a physical injury. And I think that we need to keep that in mind. Yeah. And I know that, on social media, everybody's comparing themselves to everybody else.
Yes.
And, I think it can lead people to be very depressed. What they see. And so we have to be really careful. And like you said, empathy is a big deal. How do we treat other people? Whether they have a behavioral health challenge at this time in their life or not, we just aren't very kind to other human beings at this point.
Even people with just different views or different cultural beliefs, I agree. Social media, you're right, this is a whole nother layer that certainly you and I, when we trained, had this didn't exist. No. So this is a whole nother level. And what I worry about too, besides the trolls, is the misinformation out there about how to treat these illnesses. Here's what I did. All you have to do is this or that and this kind of thing. That's really unfortunate. There is really a need, I guess, for very responsible information on social media. And I know many in our field are trying to address this, which is a good thing.
Yeah, that's a huge problem. I mean, I often have people who want to treat their illness with green tea or some kind of supplement. And we know that the longer people go without certain medications, the worse their illness can get. And it's bad for their brain if it's not treated. And there's just so much stuff out there that they can find on the internet. You can find anything that will support your point of view. I mean, I use the internet a lot when I'm doing cognitive behavior therapy. And, I had someone who had bugs crawling on them, and you'd be surprised. You look on the internet and there's whole groups of people who have that belief, right? There's also a group of people who are abusing, amphetamines and have that. So you can find evidence. You can find both of those things on the internet, but you have to be prepared for what you're going to find when you're exploring it with someone who has a serious behavioral health challenge, because there's a lot of stuff out there.
There is, both good and bad. And I guess part of our role then now has to be to help people navigate and negotiate this information. So I always encourage people, please bring this to me. Tell me exactly where you're seeing this, and let's look at this and let's examine this. And I do try to direct people as much as possible to responsible online resources. There are a number of those, of course. It's just like the news media and misinformation in the news media. There are responsible media outlets and there are less responsible ones.
Yeah. So. And how do people know? How do people know? And I think we don't do enough education in our schools about, mental illness and people having struggles and being able to identify when somebody is, hurting and how can you help?
Yeah, that's really well said. I think part of the stigma too is people, it's not only a fear of what this person will do. I think it's a fear of being shown something that could happen to you, in a sense. I've always said, I think one of the greatest fears we have as people is loss of control, particularly loss of our mental and emotional faculties and control. I think that's terrifying. Certainly I'd rather lose the use of a leg than my mind to some degree, So I wonder if some of it is that. Is this, almost like a fear of confronting mortality. There's, people who just don't even want to look at that.
Right. If I believe it could happen to you and it wasn't your fault, it wasn't something you did, it wasn't the drugs or that you have a character flaw, then yeah, it could happen to me. And I do think that's incredibly frightening. That if enough, like you said, enough bad stuff happens, I could end up in the same boat.
Yeah. Oh, I think that's very true. Well, we've outlined the problems very well, I think. Maybe we could talk a little bit for our audience about things that can be done. Are there evidence-based things? Are there some strategies that can be used to reduce stigma and to try to improve outcomes?
Well, I do think that language is important. I think that there's evidence that language and how we talk about these illnesses makes a difference. So, certainly speaking up when people call someone a derogatory term. I think that as a general society, we can rethink things. We can rethink, for example, how we get people on and off benefits, how we use mental health in terms of sick days. I think that open and honest conversation is really important. And I think curricula like mental health first aid, where we're teaching people how to identify these kinds of things and how to respond to people that are having difficulties in a compassionate way so that we can help them to get the kind of help that they might need.
Well, that's really well said. And there's many people, of course, who come in contact with those with mental illness. And several years ago, I was involved in a program to educate law enforcement on mental illness. You know about these programs. They're so important because there is we mentioned earlier athletes. There's something I call the warrior culture, that athletes, police, firemen, military have, which is you can't show weakness, and there just is a certain mentality around mental illness. And especially, I think, for law enforcement who come in contact with people with all kinds of behaviors, there is this sense that person should be able to heed my commands, and they take it personally if the person doesn't listen or heed my commands, and therefore they should be punished somehow or something like that.
Yeah, I mean, I've been involved in some of those same programs, and that when you approach someone who's having a mental health crisis with that authoritative, listen to me, approach, it's not going to work. And so we do teach our officers, all of them, about how to approach somebody with mental health challenges, how to kind of say, hey, what's going on? How can I help? Instead of, what are you doing?
Right. Stop doing
Why are you doing this? Stop doing that. Yeah.
Yeah.
So
I think it comes back a little bit. Yeah, it comes back a little bit to the empathy. I mean, I think understanding that when someone's having a mental health crisis, it's terrifying for them as well. I think it's got to be scary. Again, feeling out of control, having people react to you in the way that they do, not taking you seriously. I think it helps to understand what people are going through at that moment. And to realize, as you said, it is a temporary situation. The person's not always this way.
Yeah, and I think that law enforcement, for whatever reason, because of our society and the way it's structured, ends up being the ones who are the first responders. When somebody is, preaching in the fast food restaurant all night, people don't know how to handle that, and they end up calling the police. And if the officers aren't trained, it can escalate a situation really badly. And so it's very important that as first responders, they're trained on how to deal with it. And I think they can de-escalate the situation. And I think many times, they can just offer the person a courtesy ride to the hospital and, and, be really helpful to them, to getting them in the right place.
Well, there are many programs, as you know, that are popping up where mental health professionals are part of the first responder team, if you will, and they're brought in when the first responder recognizes, oh, this is a mental health issue. Let's bring in someone with specific training to de-escalate and to handle this. I think that's a good thing. I mean, police officers shouldn't be put in the position where they have to manage what's really a medical or mental health crisis. Again, you wouldn't ask a police officer to manage a diabetic ketoacidosis. Yet.
Right, we don't. Oh, we expect them, to do
mental health. Yeah.
Yeah.
I think along our conversation, we certainly have given people some suggestions. And again, I wonder if there are other strategies. I guess one of the biggest ones we talked about is examining our own belief system, our own way of using language, our own expectations is something we said. The way that we present our treatments, even, I think. The idea of how you present a treatment can really matter. And not making decisions for people is something I like to talk about. We maybe assume somebody wouldn't want to do this, or somebody will get mad if I say that. But that's making a decision for somebody and withholding information potentially. So I don't believe that we have to overshare and say everything necessarily. But maybe we have to reevaluate how much we do tell people.
I think we have to give people enough information that allows them to make an informed decision. And, it runs the gamut when I go to visits with the people that I see to a prescriber, because it can be, this is what you should take, to here's everything that could go wrong with every medicine.
Exactly.
And they're overwhelmed. And so there has to be, enough informed consent where they can make a good choice. But at the same time, you don't overwhelm everybody with information. And the same is true in cancer treatment, right? Mm-hmm. You want to make sure everyone understands, but you also don't want to overwhelm them with so much information that they can't make an informed choice.
Yeah. And, I'm thinking about LAIs just temporarily. And you and I have worked together a lot on various LAIs. And, I think about that's one where we often make the decision for the patient or the family. We don't even present LAIs as an option, certainly not maybe early in the treatment. And yet, again, would we do that with cancer? Would you withhold certain chemotherapies, and not give someone the range of options? So I think we have to examine our own prejudices or stigma around the treatments, as you had said. Something that occurs to me just now, Dawn, and I wonder what you think about this. What is the difference between stigma and prejudice? Are they the same thing? What are the differences there?
Well, I'm sure that stigma can lead to prejudice. So prejudice, we're going to act in a different way around people. I think that might be one of the distinctions. Stigma, we can think what we want, right? But once it turns into a prejudice, you're acting in a different way. You're putting them in a different space. They can't be in this neighborhood, or, they can't be in our hospital, or they have to use a separate bathroom.
Yeah, of course.
Then I think it can escalate, and it can become, formed in society, right? I mean, we used to say, oh, well, these people had to be treated in places that were far away from the community where they could live forever. And we've certainly changed that attitude and that way of discriminating.
That's a good point. We would remove people from society, basically, for having a mental illness. Well, that is interesting. So stigma maybe is more of a belief. Prejudice is a belief that then leads to action. Is that one way of thinking about it?
That's kind of how I see it. I don't know if that is something that would be supported by the experts or not, but that's kind of how I see it. And then it can become systematized.
Yes. Yeah, to me, for some reason, I don't know why, prejudice is a little more of a pejorative term. It has a little more of a negative connotation than stigma.
Yeah, well, nobody wants to believe they have prejudice, right?
And yet we all do. We all have biases.
And yet we all do. I mean, I've worked in mental health facilities where people are loitering in the lobbies waiting for rides that may not come for hours, because that's how our system works. And they will be stopped by the police of the institution. And what are you doing here? And why are you still here? And it's lack of training, lack of understanding. And I think that the more we're able to talk about mental illness, the more we're able to sort of say, what it is and how to live with it, I think people will get better.
Well said. That is actually a wonderful place for us to end on. I think we can wrap it up that way. There is hope here, and there's a lot we can all do to certainly, I think, being mindful of stigma and the role it plays, as we talked about, in all the different levels and all the different ways, and then to look for opportunities to combat it as much as possible. I think this is a message of hope, and I do think we've made progress. I think there's ways to go, but I'm hopeful. How about you?
Yeah, I have a lot of hope. I think, like what we talked about, empathy and being mindful and really understand everybody's got their own kinds of struggles and just being able to appreciate them for who they are.
Mm-hmm. Well said. Well, Dawn, as I said, the time passed by very quickly here. I always enjoy speaking with you formally and informally. Any parting words for our audience?
Yeah, I would just say check yourself. When you have an automatic thought about somebody, because of the way they look or they're presenting, that they might be having a mental health challenge, just check yourself on what you're thinking and whether it really is true. So.
Oh, I love that. Check yourself. That's terrific. Well, I want to thank you, all the audience. That's all the time we have for today for this particular NEI podcast. Thanks so much for listening, and check out our other offerings. We have a number of podcasts now. We've been doing these for several years. And for more information on NEI's various educational offerings, please go to our website, neiglobal.com. And you can certainly find our podcasts anywhere that you get your podcasts. So this is Dr. Andy Cutler saying thanks for listening. Look forward to talking next time.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit neiglobal.com.